So much. Thank you, Dr. Shikha, for stitching up such lovely case and talks together. And thank you so much for inviting me. So there are two aspects of the talk. One is how do you manage the recurrences and how do you follow up these patients. Now, recurrences, multiple sclerosis or demyelinating disorder is a neurological disorder where optic nerve is involved because of that systemic disease. So most of the recurrences will be managed by the neurologist. However, our role would be to guide neurologists and sometimes even indicate to neurologists whether recurrence is happening or not happening. So how do we do that? So there are several scenarios of optic neuritis that we would be dealing with. One is where we know that this is a confirmed case of multiple sclerosis. How do we confirm whether it's a case of multiple sclerosis? That's something which is outside the purview of this talk. And how do we follow up a patient who had a first attack and we still don't know whether the patient had, what was the etiology of the optic neuritis? So let's say first is a confirmed demyelination, which we picked up on MRI. Now, obviously, demyelination, the commonest etiology that we deal with in demyelination is multiple sclerosis. However, we have to remember that antibody-mediated optic neuritis can also produce demyelination, and they have a different kind of prognosis. They have a different clinical picture, and our role there is little more than a patient with multiple sclerosis. So let's talk about multiple sclerosis and how do we follow up these patients in our OPD. So what are we looking for? We are looking for recovery. We are looking for what happens to the optic nerve disease process and the clinical picture when you stop steroids, and how and if at all there is a progression of the disease. So how do we get to all these three? These are the tests typically that we would do in a patient who had optic neuritis and who we are following up. So the first scenario in case of multiple sclerosis is what happened to vision. So what do we expect? A confirmed case of demyelination because of multiple sclerosis would follow a very typical route in more than 95% of the patients. Generally, when the patient receives steroids, once a course of steroids is over, patient would generally report improvement in vision. And more than, as I said, 95% of these patients by the end of 6 weeks would come back to baseline visual acuity. When we say baseline visual acuity, we are only talking about the Snellen's visual acuities. That's something which we are looking for. Now, if there was a deviation, let's say if patient said that with 1 or 2 doses of steroid, his vision or her vision went from 1 or 2 by 60 to 6 by 6, that's not very typical of demyelinating optic neuritis, and we might have to look for other etiology causing the inflammation of the optic nerve. What if at the end of 6 or 8 weeks vision did not improve? It can happen in a very small number of patients with multiple sclerosis. However, since that's not typical, we might also have to now start looking for other etiology. We are mainly looking for NMO and MOG. The other 3 tests, RAPD, color vision, and contrast sensitivity. All patients, as Vidya had mentioned, all patients with unilateral optic nerve problem would have RAPD, and that's the most objective test of optic nerve function. The RAPD may not directly parallel the visual acuity because RAPD is dependent on surviving neurons in the affected eye. So while the visual acuity might recover faster, you might still see RAPD for little longer even if the attack has subsided. Color vision dyschromatopsia actually lasts much longer. In fact, even after a few months, patients still can report washing out of colors, and you may find that patient may not have recovered full visual acuity, color vision acuity on HTRS chart. Same goes with contrast sensitivity. However, contrast sensitivity would improve faster than color vision. What about visual fields? According to me, visual fields is the most important parameter which we should be looking for. Because one, of course, we want to know whether the visual field defect has cleared up. However, the subtle second attacks can be picked up by visual fields even before patient reports the dramatic decrease in vision, in Snellen's vision. Mean deviation in Humphrey's visual field is one of the good indicator to say whether patient is going into attack. Any difference between the previous field in a mean deviation in a reliable visual field, which is more than -3 or 4, our antenna should be up. We may not start treating them, but maybe we can have those patients followed much faster. OCT, and I'll defer a lot of questions on OCT to our chief instructor, Dr. Shikha, who has done a lot of work on OCT. But OCT has an important role to play in multiple sclerosis when we are following up these patients. There are, and let's look at it in VEP. According to me, VEP really does not have a major role now. VEP was a cornerstone of an investigative modality in multiple sclerosis before the MRI era, where we used to detect increased latency even in the absence of clinical disease in the other eye, and that used to be an indicator saying patient might go into multiple sclerosis. Now that role has been taken over by MRI. So as I said, pupil color vision and contrast sensitivity may not follow the visual acuity directly. What are we looking for in OCT? OCT generally would demonstrate thinning of retinal fiber layer and GCC. Can the thinning tell us a little bit about what would have caused optic neuritis in an ambiguous scenarios? Well, it is said that if patient has multiple sclerosis, maybe you may have more thinning in the temporal quadrant versus an NMO-related optic neuritis where there would be a global thinning of retinal fiber layer. However, I don't think we can, at this moment, take this as a final answer. OCT, like VEP, can demonstrate subclinical thinning in the eye, which did not have a clinical disease, and that can tell you that maybe patient has a severe disease process. There have been papers which have tried to use OCT as a marker of a disease activity in the brain. It is believed that maybe secondary progressive multiple sclerosis versus a remitting multiple sclerosis, SPMS might have a little more severe thinning of the retinal fiber layer versus RRMS. And similarly, there have been papers which have said that OCT can be used as prognosticating factor for the future clinical disability. To my mind, I don't think it is still mature enough to use it in a clinical setting, but maybe something that we can look at more closely. And what is our role in instituting interferons? Well, that's something which obviously would be a neurologist's call, but we can contribute to defining a high-risk patient. So a patient a female with a MRI positivity and let's say retrobulbar neuritis, you know that she is a high risk, versus the same patient having hemorrhage on the optic disc. ONTT told us that if there was a hemorrhage on the optic disc, that probably gave a little more protection to that patient for the future development of MS. And maybe disease-modifying agent like interferons can be deferred a little bit in those patients, and that's our role. NMO, again, we follow the same protocol to follow up the patient. However, one has to remember that NMO is a much severe disease and vision improvement is not really as much as what we expect in multiple sclerosis. Rest all remains same. As I said, OCT, you'll expect much more thinning in patients with NMS. I'll take one more minute, Shikha. What about relapse and MRI? MRI in multiple sclerosis generally neurologists call, but they would do it every 6 months to 1 year, because you have to remember the basic difference between multiple sclerosis and NMO. Multiple sclerosis, once the disease process starts, the damage is done by continuous neurodegeneration. While in NMO, the damage is actually done by an attack. So between the attacks, if you can prevent attack, you can prevent further neurodisability. MOG is another antibody which causes an optic nerve damage. This has a little more favorable prognosis than NMO. And again, most of the time, MOG would be monophasic versus NMO, which can have recurrence. Now, I'll end with another case just to demonstrate as to what is our role. As I said, we do have a very significant role to play. A very senior physician in Hyderabad, his younger brother developed multiple optic neuritis, and the treating physician, and since a physician had his own neurology team, so they were not interacting with our neurology team. So they were really very worried. They suspected, the neurology team suspected that the patient has optic neuritis because of NMO, and they started on multiple treatment. Now, patient did well with the acute treatment, his vision improved. However, after 6 months, patient reported that he has a loss of vision in the same eye. And patient was started on steroids. The MRI was done locally. Patient was also put on rituximab, mycophenolate, and all of the treatment. However, when the patient was sent for follow-up after starting all this, we realized that there was no RAPD, there was no change in clinical ophthalmological parameter. And it turned out a little later the patient actually had a non-organic vision loss. So that's something which, while we can also guide them to say how severe the vision loss is or optic neuropathy is, our role also is to say that there should not be, because all these medications come with a significant side effects for a long-term treatment. So that's something which is our role. Thank you.
Great talk.